Welcome to another episode of LIMBWatch series on Diabetic Foot Files, a series dedicated to improving diabetic foot surveillance, early detection, and limb preservation through evidence-based conversations with leaders in the field. In today's episode, we're joined by the amazing Dr. Thomas Hardiman, a respected podiatric surgeon with a passion for diabetic foot care, biomechanics, and preventing lower extremity complications. He has more than 40 years experience in foot and ankle. Throughout his distinguished career, Dr. Hardiman has dedicated himself to advancing diabetic foot care with a particular focus on peripheral neuropathy, preventative screening, and improving outcomes for patients at risk of diabetic foot complications. In addition to his extensive clinical experience, he has also been involved in the development of medical monofilament technology used for diabetic sensory testing, giving him a unique perspective on one of the most important screening tools in diabetic foot care. Dr. Hardiman brings valuable clinical insight into one of the most simplest yet powerful tools we have for preventing diabetic foot ulcers and amputations, the 10-gram monofilament examination. He is also the medical director of the medical monofilament manufacturing, that's alliteration for me. Established in 1999, the medical monofilament manufacturing has made it their mission to create high-quality medical device that allows both patients and clinicians to perform a simple test for the loss of protective sensation. So welcome, Dr. Hardiman.
Thank you, Dr. Hutchinson, for having me here. It's an honor.
Well, thank you. So, Dr. Hardiman, for clinicians who use it every day but don't fully understand it, what exactly is a monofilament and from the materials to the engineering perspective of it?
Sure, great question. Before we get into that, I just want to remind our audience that, we're talking about a screening test here called the 10-gram monofilament. And it's used to screen people who are living with diabetes for sensory loss in their feet. We call that severe neuropathy, loss of protective sensation. And I just want to quote Bishop Desmond Tutu here, who inspires me every day. I have his quote hanging on my monitor in my office on my computer. And he once said, we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And I think this is particularly a relevant quote for those of us in the diabetic foot care, sector. And, we don't want to wait for these people to walk through our clinic door or the emergency room once they have an ulceration. Our goal really is to prevent that first ulceration. So we have tools in our, toolbox that can help us do that. One of them we're talking about today is the 10-gram paper handle monofilament, which I came across my own practice in the early 90s. I was introduced to it through the lower extremity amputation prevention program that the Bureau of Primary Health Care and Human Services Agency of the federal government in the United States developed the particular device we're talking about. That's the device that I helped create a manufacturing business called Medical Monofilament Manufacturing back in 1999 to help the Bureau of Primary Health Care and their LEAP program have access to the highest quality, most superior paper handle 10-gram monofilament we could possibly make. So a monofilament, without any further ado, is a class 1 medical device that's used for screening people's feet for peripheral sensory neuropathy. And it consists of a strand of filament attached in a perpendicular fashion to a handle. This handle happens to be, in our case, at our company, a high-grade cardboard material, but it could be plastic or metal. Aspect of monofilament testing was popularized in the 60s by Dr. Sems and Dr. Weinstein, but their work really an extrapolation of the earliest sensory testing that was done by Dr. von Frey in the late 1800s. And he was using horsehair and porcupine hair and various animals' hair to check for different levels of sensitivity along dermatomes of the body. And Dr. Paul Brand, who was very, very instrumental in helping us understand what the whole etiology behind neuropathic ulcerations in the feet were, based on his work with insensate people that were suffering from Hansen's disease or leprosy. And Dr. Brand worked in Carville, Louisiana, with the LEAP program, and he challenged the engineers there to come up with a very inexpensive tool to check for sensory loss. And they came up with this paper-handled 10-gram monofilament. And that threshold of sensitivity was established in the mid-'80s by some great work by Dr. Sims and Dr. Burke out of the LEAP program. And that has been the basis of us having this tool that we use for screening, a very easy test to check for our patients to see if they have adequate sensation. And the filament's pressed against the skin in a perpendicular fashion until it buckles or creates a C shape and bends. And this is then transferring that force to the skin, which is 10 grams of force directly to the skin. And this is tested on the plantar aspect of both feet.
Oh, wow. Dr. Hardiman, you just taught me something. Wow. Okay. So,
Not for a
so
good start.
I did not know any of that. So thank you so much. So what is actually happening at the level of the nerve when a patient cannot feel the monofilament?
Right. That's a great question. Without getting too technical, a 10-gram monofilament is applied to the skin and it buckles again and transfers the 10 grams of force to large myelinated nerves in the skin. People sometimes talk about the Pacinian corpuscles, but those aren't involved in 10-gram monofilament testing because those corpuscles are in the deep dermis and they're more sensitive to high frequency vibration. With the 10-gram monofilament screening test, we're talking about Merkel discs and Meissner corpuscles. I don't know if those ring any bells back in your histology days, but
Of
those are
course.
they perceived messages of force and they relay that message to the sensory nervous system via the myelinated afferent sensory nerves, and those are located in the dorsal ganglia of the spinal cord, and then they're transferred to the rest of the central nervous system in the brain. So I hope that's not too technical, but again, the force is being transferred, it's being picked up by afferent nerves, and then sent into our CNS, and the brain would perceive that message.
Okay, thank you, Dr. Hardiman. So can you walk us through the relationship between the monofilament testing and the loss of the protective sensation? And how does it connect us to the broader pathology of diabetic neuropathy?
Sure, sure. In a person with peripheral sensory neuropathy, the nerve itself has been damaged as a result of a process of high sugars circulating in the bloodstream, a biochemical type of reaction we sometimes refer to as glycosylation, where things get somebody once said to me, think about sugar in water, and when it starts to get a little bit sticky, and if you ever had sugar water on your hands, it's kind of nasty. And so people that have high sugar circulating in their bloodstream, this stickiness damages cells and structures, and the capillary damage nerve survive start to get clogged, and it destroys the covering or the coating or the insulation on the nerves called the myelin sheaths. And once those sheaths, the myelin's damaged and it cracks and it becomes interrupted, it interferes with the ability of that nerve to transmit signals properly. So this happens to people with diabetes over a period of time where their blood sugars may be elevated. And over the course of 5 to 10 years living with diabetes, the majority of people are going to experience some sensory loss. It's estimated up to 50 to 60% of people will eventually lose protective sensation entirely in their feet. And this type of neuropathy in people living with diabetes is symmetrical. So it's both feet, usually at the same, progressing at the same time. And it progresses on the plantar aspect of the feet. And it starts in the tips of the toes. And so it progresses distally to proximally. So it starts in the tips of the toes and eventually progresses down into the heel.
Okay. So thank you, Dr. Hardiman. So, Dr. Hardiman, can a patient have a normal monofilament testing and still be at risk for ulceration?
Yes, they can. I mean, other than neuropathy, there are certainly other risk factors for foot ulceration, such as peripheral arterial disease, visual impairment, structural deformity of the feet. And then you pair that with, sometimes improper footwear or lack of footwear and, poorly controlled diabetes. And, sometimes people have chronic kidney disease, which is also a separate risk factor. So it's possible for someone to have a normal filament exam. And again, the 10-gram monofilament screen test is, again, checking for late stage severe neuropathy. So sometimes say that that's when the cow is already out of the barn, right? I mean,
Mhm.
it's a little bit late in the game, but it's better to be aware of what's happening with your patient, at all times.
Thank you. So, how does the monofilament testing compare to the vibration perception threshold or the tuning fork examination?
Great question. The 10-gram monofilament screen test measures large, nerve fiber function, and it's measuring pressure sensation to predict risk of foot ulceration and subsequent amputation. So it's less sensitive for early neuropathy detection than vibration, but is still considered a very practical risk stratification tool. Vibration perception threshold testing, commonly we do that with a 128 hertz tuning fork. There is a more expensive instrument called a biopiezometer, which is costs a lot of money, and most standard clinics don't have that. So we use the tuning fork, which is adequate for clinical testing. And this, again, is testing the Pacinian corpuscles in the deep dermis, and it's definitely more sensitive to sensory loss than the 10-gram monofilament. So the American Diabetes Association and the International Working Group of Diabetic Feet suggest doing both tests on your patient because it increases the sensitivity and specificity of both tests, actually.
Okay. Oh, wow, I didn't know that. So that they recommend doing the both tests.
Yes.
Okay, thank you. So, what's some of the most common mistakes clinicians make when they're performing the monofilament testing?
Well, the biggest mistake would be not doing it at all, right? Uh,
Yeah, definitely.
and I just want to mention that because these screening tests, the monofilament test has been around for 40 years, but it's still underutilized, which is a sad thing. So I think, by ignoring the need to do the test is probably the number one mistake. But I think the next thing I would say, make sure the patient understands the purpose of the test. Take a few minutes to just explain what it is we're testing and why we're testing it. And then I, encourage people to take the monofilament itself and show the patient on your own finger or
Mhm.
your hand, what this is going to do, and reassure them that it's not painful, it's not invasive. I recommending flexing the monofilament twice on the dorsum of the hand, and just and then touching it. Ask the patient, "Can I touch it to your hand?" So that you
Mhm.
understand what it is that we're going to be testing you and what that will feel like. Most people have adequate sensation in the hands, but if not, you could do the forearm or the elbow or some area of exposed skin. And the other important thing is make sure you have the patient close their eyes during the exam.
Mhm.
We don't want any visual bias going on, right? So you could have them close their eyes, or even some people will have a screen, maybe at the level of mid leg or knee to screen the patient's vision. And again, this is a forced choice, so it's a binary test. You're going to ask the patient, do you feel it? Yes or no, now or now. So there's different variations, but essentially you're asking the patient to just affirm when they feel something touch their foot. And you can do false testing where you don't actually apply it and you ask the patient,
Mhm.
do you feel it now? And see what their response is. And then you can do a actual application of the monofilament and have it buckle at 10 grams and say, do you feel it now? And it's a yes, no type of response that you're looking for.
Wow, yeah. I really do like monofilament testing because I think it's one of the fun tests. I have like some patients that think it's fun. They
Mhm.
are excited when you say close your eyes, and you're completely right with the let the monofilament touch your hand because the
Yeah.
moment they see it for the first time, if it's their first time seeing it, they think it's a needle. They think you're about to
Right.
poke them. Yeah.
Yeah. Yeah, absolutely right. That's very important to reassure the patient.
Yes. So, how often, Dr. Hardiman, should a monofilament be replaced? And are most clinicians using expired or inaccurate monofilaments?
Well, I hope not, but we have to keep in mind all material experiences, fatigue of its physical properties with repeated use, right? So eventually the material will fatigue, the filament will fatigue, and you're not going to get a reliable transfer of force. So it's going to start buckling at a lesser force, maybe 8 grams and 6 grams and 4 grams. So at medical monofilament manufacturing, we strongly advise single use of the paper handle monofilament to ensure
Mm.
best results of screening and decrease risk of cross contamination, and
Okay.
as well as practicing universal precautions, right? We just have to keep that in mind. But I mean, to your point, I highly suspect, I do believe, and accept the fact that, there more than, more likely than not, there are expired monofilaments and, you know, inaccurate monofilaments that are being used out there in the real world. There's no doubt about that. And that's an unfortunate fact. And, I would like that not to be the case, but hopefully, over time that'll become less of an issue.
Oh, that's such a good point you just made, Dr. Hardiman, about cross contamination and single use of the paper monofilament. So, thank you for explaining
Yeah,
that.
I actually never thought of that myself, but I came across a paper that was written on that topic, and that paper was written pre-COVID. And I really, it made me stop and pause for a minute because I had never thought of that. And maybe a low risk, but there's definitely a risk. So I think
Yeah.
that's another reason to use a single use.
Yeah, no, definitely, especially with our diabetic patients with their
Right,
skin, their immune system already down.
right.
So, Dr. Hardiman, what are the correct anatomical sites for the monofilament test, and why do they matter so much for us to have the right sites? Because it says it on the monofilament, like the picture.
Yeah, yeah. So initially, when we started doing this type of testing, screening 30 years ago, we had multiple sites. We had, up to 10 to 12, some on the dorsum of the foot, many more on the plantar aspect of the foot. But it turns out that, and this is research, done by the International Working Group of Diabetic Foot and the ADA scientists, that as few as 3 or 4 sites on the plantar aspect of each foot is all that's necessary. And this is now accepted by the ADA, American Diabetes Association, and the American Podiatric Medical Association. Then these sites are the plantar aspect of the hallux, sub first metatarsal head, sub third metatarsal head, and sub fifth metatarsal head. And it matters because these are also noted to be the most frequent areas of ulceration, right? So it's just interesting that it corresponds to those anatomical sites. But the other thing, and this is probably more practical than anything, you know, all doctors are super busy and overwhelmed with so much responsibility and so many tasks to be done. The fewer number of sites, the less amount of time, and time is of the essence in a busy clinic. So I think it's, very important to respect the fact that, this test has to fit into the workflow of a busy
Mhm.
clinic, busy medical staff. And so the more we can simplify, the better.
Okay, yeah, thank you. So, Dr. Hardiman, if we walked into 10 different clinics today, how many would you think be doing this test correctly?
Well, again, we have to accept reality, right?
Yeah.
Uh,
Mhm.
and again, we have to stop pulling people out of the river. We need to go upstream, but and find out why they're falling in. But the fact is that the literature tells us that only 30 to 50% of people get a proper comprehensive diabetic foot exam annually. So that number is extremely disappointing. It's much lower than you and I would like it to be. And that's one of the tasks, I think, at Medical Monofilament, you know, yes, our mission is to manufacture the most superior premium quality 10-gram paper handle monofilament in the world. But our purpose really is to partner in prevention of diabetic foot ulcerations and subsequent amputations. And so I take it very seriously that, we don't sell monofilaments, we partner in prevention. That's what I keep telling my staff, and it's like, we're doing something more important than, manufacturing a product and trying to sell it. We're really trying to partner with those that are interested in prevention.
Okay. Dr. Hardiman, I kind of skipped over some of the questions, but should monofilament testing be combined with other modalities for better accuracy? Because you kind of mentioned a little bit with the tuning fork as well.
Yeah, yeah, absolutely it should. And, that's been suggested in multiple studies, from multiple countries and multiple groups. And, we've just accepted that as, you know, absolute mandatory practice that it be combined with another modality. And the tuning fork is the most practical for most clinicians.
Mhm. So, Dr. Hardiman, let's say a patient you did the monofilament test on a patient and they didn't feel any of it, right? Loss of productive sensation. What do you recommend the next steps for a clinician to do after that?
That's
Mhm.
re- yeah, that's a really good question. And I feel our responsibility at that point is to inform the patient that 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 alarm system is broken,
Mhm.
and that what they once had is lost, and it's probably lost permanently and unlikely to come back. So this becomes a challenge then of patient education and kind of risk mitigation, where I kind of joke sometimes with people, just because I don't want them to panic, right? And
Mhm.
I don't want them to be fearful. But so what I try to with my patients, I would try to educate them, and I would say, although we're going to have to substitute it with another modality. So we're going to have to incorporate more preventative measures like visual inspection. And that's going to become more mandatory for you, even though we would suggest it anyway. Now it's not something that's kind of nice to do. It's something you really have to do in order to avoid problems. And we're going to have to be more cognizant about the fit of your footwear, and making sure there's no foreign objects in your shoe by taking your insole out and shaking it out every day, and being careful of, burns and not getting into a bath before you check the water with the back of your elbow or your hand, and realizing that that mechanism that used to give you a message when you have a problem, or if you're walking on a pebble or sharp object that's penetrated the sole of your shoe, that's no longer there. So the only way you're going to know if you have a problem is to see it. And if you can't see it yourself clearly, you're going to ask a friend or a family member to help. And you're going to say, can you look at, please, do a buddy check. I'll look at your feet if you look at my feet, kind of thing. So it's a little bit of a lifestyle adjustment. And I try to reassure patients that if they are vigilant, that just because they've lost protective sensation, it doesn't mean they're going to definitely develop an ulceration, although their chances of developing an ulceration are 7 to 8 times higher. But if they can commit to doing more visual inspection, and being more careful with their footwear and not walking barefoot, they can, again, avoid that first ulceration.
Oh, well, thank you so much, Dr. Hardiman, about that. I know that was like really impromptu, but I just had to ask the question.
No, that's a great question.
Thank you. So, what goes into manufacturing a high quality monofilament?
Well, at our company, Medical Monofilament Manufacturing, our goal has always been to be the best, and to create a superior premium product that's best in its class, and that really starts with design. And again, we didn't invent this product. Again, it was invented in Carville, Louisiana, in the early '90s, and we started making it in the late '90s because they were having trouble with quality. And we looked at the filament and we said, we can do better. We can use better quality materials. And we invested in building machines that are highly automated and robotic. And we've invested almost $1 million in our machinery that manufactures these products. And I think that the quality control standards that we have within our manufacturing processes, which are patented, really ensure our quality, is guaranteed. And above and beyond that, we have great people working in our company that really take customer care quite seriously. And so all those things together, I think, is what results in our high quality.
Oh wow, Dr. Hardiman, that's amazing. So how did you pretty much explained this one already about consistency and precise force calibration of the monofilament. But are all monofilaments on the market created equal?
No, I probably have the largest monofilament collection in the world. And
Oh, really?
yeah, I've looked at I try to acquire all our products from any competitors, and I test them in house, and it's really sad that the quality is so varied. And there's there in the literature, there's some great articles that talk about this problem, and
Hmm.
our process is different. We are completely automated, and our patented manufacturing process is very, very sophisticated. And we have inline these are sensors that are computerized load sensors. And we actually test the buckling force of each and every monofilament that comes off our line. And then we have a video inspection process that is computerized as well. And it looks for that perpendicular relationship between the monofilament and the handle. And then last but not least, we do batch testing on all lots of our product. And we do the batch, we do the individual testing of monofilament that comes off our line quarterly, every 3 months for 2 years, to make sure that it's retaining the 10-gram force. So I guarantee you no one else is doing that type of quality control in this industry.
Oh, wow, Dr. Hardiman, that's impressive.
Thank you.
If if there's one thing every diabetic patient should know about their feet before leaving the doctor's office, what do you believe it should be?
If there's one thing
That
that,
every diabetic patient should know about their feet before
yeah,
leaving the doctor's office?
I think that's a great question, but I would say that your feet should last a lifetime, and with proper care, they can. And there, unfortunately, you probably met patients like this that feel that their fate is sealed once they have a diagnosis of diabetes, that they almost feel like the inevitable is about to happen to them, and they've lost control over their fate. And if they've had friends or family that have lost, feet or legs as a result of diabetes, they almost feel like their their path is going to be the same, and that they don't have any control. And that is something I think is important for patients to understand, that they have control over their own health and their foot health all as well. And that this is a team sport, and they're part of the team. And I mean, we see these patients in our office every, 6, 8, 12 weeks, maybe, or twice a year, or once a year. It varies depending on the individual, but it's what's most important is what they're doing outside of our office in their home and in the community. And they have to commit to their foot health just like they would, any other part of their body's health.
Oh, wow. Okay. Thank you, Dr. Hardiman. I think that's the end of all the questions that I have. So we're going to go into the rapid fire questions.
Oh, this is the fun part, huh?
I hope it's fun. I hope it's fun. Okay. What percentage of diabetic foot ulcers do you, in your opinion, believe could have been prevented with earlier screening, like with a monofilament?
Well, this isn't my statistic, but the literature indicates that 80 to 85% of diabetic foot complications are preventable.
Yeah. What do you think is the biggest misconception about neuropathy?
The biggest misconception about neuropathy,
Mhm.
uh, I think probably that it's inevitable, that it's, something that everyone will acquire. And I think th- it's very important to have people understand the relationship between their blood sugar
Mm-hmm.
and the development of complications like neuropathy, retinopathy, nephropathy, and just a slight elevation of the A1C outside of your normal range over a period of time will contribute to this. So I would say keep your A1C in check,
Mm-hmm.
and that will decrease the likelihood of any of these complications
I
developing.
have I have a little side question. This is for my own. When, in your opinion, do you believe in referring to neurology?
Well, especially so in other words, I have a patient, they have neuropathy. Do I
Mhm.
send them for a neurologist? Is that what you're
Mhm.
asking?
Yeah, for a referral to a neurologist, like for a full evaluation, like a nerve conduction test or something like
Yeah.
that.
Yeah, I think that's a really great question. And I think especially in cases of painful neuropathy, where patients are really, having that disturbing tingling and burning that's really hard to control with various medications. And I think a neurology exam is very important. And I would also like to mention the importance of screening patients, for, vitamin deficiencies as well.
Mm.
B12s, especially, we know that the B vitamins tend to be sometimes decreased levels in patients with neuropathy, particularly, taking metformin.
Mhm.
And that's something to really keep an eye on. So whether it's a neurologist or primary care doctor or endocrinologist, again, we need to communicate as part of a multidisciplinary team with our colleagues.
Okay. Dr. Hardiman, what is the most memorable patient who taught you a lesson about neuropathy?
Oh, wow, there's so many. Wow, that's. I'll tell you, and this isn't the patient. Well, so I had a patient that had a heel ulcer, and he had lost protective sensation, and we'd get the ulcer resolved. We would get the proper wound care going and the offloading going, and take care of infection, whatever it was. And then let's say 6 to 8 weeks, he goes back into his regular footwear, and sure enough, 2 weeks later he comes back, the ulcers reoccurred. And this was really like puzzling me, and I was like, I can't figure out what's going on here. And I had neglected to look at the patient's shoes initially, and when he first presented with the ulceration. So when he came back with his reoccurrence, hopefully it was just the first time, but I can't guarantee it. It might have been the second time. I don't know. I finally looked at the bottom of his shoes, and he had a huge nail that was penetrating the bottom of one of his shoes. It lined up perfectly to where his ulceration was. And it turns out that his hobby was refurnishing furniture, rebuilding furniture. And he would strip the upholstery, and these tacks and nails would fall into on the floor. And he picked one up in a shoe. But I guess the thing that, I really, really, and I know I apologize profusely to this patient, I neglected to look at the bottom of his shoes as contributing, risk factor. And it never happened again. So really committed that I wasn't going to wait for problems to happen. I was going to start looking at every person's shoes every time they came to my office, regardless, whether they had an ulceration or not, if they had diabetes. And I would also take out the insoles and shake them out on a towel, paper
Mm.
towel. And you would be surprised what I would find in those shoes. I've found coins, I've found jewelry, I've found candy. I've found I've found
Candy.
paper clips. I returned all the money and jewelry, I promise. But I even found a small Lego from a grandchild that was playing.
Oh.
Yeah, so I, I guess keeping my eyes open for the risks of foreign bodies and footwear was a big lesson.
Oh, wow, that's impressive. So, Dr. Hardiman, if a patient says, "My feet don't hurt, so they're fine," what's your response?
I would say pain is a gift, and the
Mhm.
absence of pain is a risk factor. So, pain is not really something to be avoided. It's our body's alarm system, and it helps us it brings our attention to an area of our body that may need extra attention.
What's one innovation in diabetic foot care that you're most excited about at the moment?
That's great. Well, there's so many things happening, right? I mean, I'm really excited about AI and what that's going to help us do in terms of managing populations of people and going upstream again and being a predictor of problems in terms of like if we can have AI help us determine what patients are at most risk in terms of doing risk stratification and what patients we need to keep a closer eye on. I think that's going to be a huge benefit to us because we can get these people into the system sooner and not waiting for them to present after the event
Oh,
of
wow.
ulceration. Yeah.
Okay. Just a few more. What's the best advice you ever received as a physician?
Well, I think the best advice I ever got as a physician is to treat that person in our exam room the way you would treat a friend or family member. They deserve the same level of care, the same level of empathy, understanding, patience. And that's probably the best advice I ever got.
Mm. Dr. Hardiman, you actually gave me some of the best advice I ever gotten. You were the person, yeah, because you said trust but validate, and then go where you're appreciated.
Oh,
So,
okay.
so yeah, yeah, you helped me.
Well,
What motivates you to keep fighting against amputations?
somebody asked me the same question the other day because I'm going to be 70 years old in September, and it's like, why aren't you going to
Oh,
retire? Why are you, why are you still like concerned and passionate about this? And it's almost like I feel so blessed to have been a physician and to be in this specialty. And there's so many preventable amputations that are still occurring, and it's predicted to double by 2060 in the United States. And we already have over 150,000 amputations annually, over 150,000 amputations. Every 3 minutes, someone is losing a limb in the United States due to diabetes. And they say it's every 20 seconds globally. And if we can prevent 80% of that, well, I mean, we have an obligation to do that. So I just feel like the work is unfinished. And if I can help, you know, kick the can down the road a little further and help younger doctors like yourself, pick up the baton where we leave off, and we have a lot more to accomplish. And there's too much unnecessary suffering and death that is occurring due to something that's very preventable. And you haven't asked me this question yet, but I think you sent me a question and it said, what's one thing every clinician should stop doing immediately? And I would just want to answer that question by saying, stop calling it a silent epidemic, because I think that's such a mischaracterization. There's no reason. I mean, it's such an oxymoron that we would have an epidemic that's silent. Have you ever heard of such a thing? I don't even think it's possible. And this should be the not very silent, highly preventable epidemic that we're dealing with. So I really despise the use of the term silent epidemic. I think that disempowers people. It makes people kind of complacent and almost forces them to accept the status quo.
Thank you, Dr. Hardiman. So, what's one habit that you think could save most limbs?
Very simple. Daily self-inspection or inspection by a family member of the feet.
If you can teach a new podiatrist about monofilaments, like if you only had 30 seconds, what would you say?
We can't manage what we can't measure, right? So we have to check for the LOPS. You see what you look for and you recognize what you know.
Mm-hmm. Okay, I have two more questions. If you
Okay.
weren't a if you weren't a podiatrist, what career would you have chosen?
Oh, you snuck that one in, huh? Well, I probably would be making movies with Matt Damon and Ben Affleck.
That's You're so- really, you wanted to be an actor, Dr. Hardiman?
I'm just kidding. I have no idea. I just that came off the top of my head. Thank you.
Okay, and what's one thing people would be surprised to learn about you?
That I really don't identify. I mean, as much as I love being, a doctor, my
Mhm.
identity really comes from being a husband and a father and a grandfather, a friend, a brother, a neighbor. Because there is more to life than medicine.
Oh, thank you, Dr. Hardiman. That's perfect. So that wraps it all up when it comes to the rapid fire. So as we wrap up this episode of Limb Watch, I want to extend an amazing, sincere thank you to Dr. Hardiman for sharing his expertise and reminding us that preventing amputations don't always start with the newest technology, but it actually requires consistency performed with the fundamentals as well. And this has been Limb Watch, and thank you, Dr. Hardiman.
Thank you, Dr. Hutchinson.
Yes. And I'm Dr. G, and take care of your feet because they take care of you.
Thank you.